And we're back with Chad Cook. Chad, I really appreciate you coming on. This is your first time on our podcast. For people who maybe aren't familiar with you, can you just give us an intro on yourself and who you are?
Absolutely. First of all, Chris, thank you so much for inviting me. I had a chance to listen to some of your podcasts. You get some really top-notch speakers on here, and you do a great job. So congratulations on really building a strong podcast. Um, about me, I'm a physical therapist. I have been for 35 years. I currently am a tenured professor at Duke University in the southeast part of the United States, state of North Carolina. I have primary appointments in the Department of Orthopedics, and I have secondary appointments at the Duke Clinical Research Institute and the Duke Department of Population Health. I am primarily a researcher. I do a little teaching. I'm in the clinic only when I treat the patients that are in my trials, but love research. That's been my life, I guess, for the last 5 to 10 years, and I love our profession. And I feel very lucky to be able to share some of the things I've learned to other people.
Yeah, I initially reached out to you for a different topic than we're not going to dive into today. It was a systematic review that you were a co-author on, and we're actually going to record an episode with the lead author of that paper in a few weeks. But you were nice enough to bring up other topics for us to dive into, and I really wanted to let you have the autonomy of what you wanted to talk about. And you brought up this area of research and this topic of specific and shared mechanisms, which we really haven't discussed a ton in prior episodes. And this seems like a lot of your current interest in research. And I think it's going to be a great conversation. Let's just start with the definition and really what is specific and shared mechanisms and why is it important to study them?
Yeah, so let's start with mechanism. There are disease mechanisms, which are exactly like they sound. Those are essentially the physiological or psychological components that are related to a specific disease. They're the cause of that. The area that we're going to talk about is treatment mechanisms. And these are the physiological or psychological components that are related to our interventions. In other words, it's the why our interventions work. And if you don't mind, I'll give you some examples as we break down specific and shared. Specific mechanisms are those that are unique to the intervention itself. So if we think of a cortisone injection, some of the specific components of that is there's instantaneous pain relief because there's often a lidocaine injection with it. It pushes all the water out of that particular area, so it reduces a lot of the inflammatory mediators that infiltrate around a particular area. It stabilizes the neural membrane of the cells in that particular area, and it's got a neuroimmune effect too. So those are the specific effects of cortisone. If we think of something that's more home to us as PTs, like exercise, the specific effects of exercise are things like increased cardiac output, increased oxygen delivery, metabolic changes, improved elasticity of the vascular system, hypertrophy of tissue. So all of these are specific to an exercise approach, especially a resistance exercise approach. Now, shared mechanisms are a term that what I've seen, most people don't understand them very well, or they're relatively new. These are used a lot in the psychological literature, but not very much at all in the physical therapy literature. But shared mechanisms would be those mechanisms that occur that lead to changes in clinical outcomes that are not specific to one intervention. And let's take exercise and cognitive behavioral therapy, things like changes in negative cognitions, a reduction of attention or catastrophizing or hypervigilance of a person's condition, improvements in therapeutic alliance, changes in stress responses. All of these things can occur through different interventions, and it leads to a shared effect. And so many different things can lead to that same mechanism.
Going to that initial specific mechanism, I guess the opposite or the other would be non-specific effects or mechanisms. Can you touch on what those are?
Yeah, so non-specific effects, and it depends essentially who you read on that, because some people will lump in natural history into nonspecific effects, or regression to the mean, or a number of other things. I think natural history kind of deserves its own place, especially for musculoskeletal conditions. It seems to have its own effect. Nonspecific effects are those things that essentially are very similar to shared mechanisms. Those are things that are not specific to a selected intervention and can include a lot of the aforementioned elements that I talked about. The placebo effect is a non-specific effect. And people get placebo and placebo effect completely mixed up. Placebo effect is an amplification of the effect of an intervention based on the patient's beliefs and thoughts. So that's a non-specific effect. And also, specific mechanisms are sometimes called specific effects. So I know there's a lot of terminology thrown around with that one. But I would, if I had to bundle these together, specific effects and specific mechanisms, same thing. Non-specific effects and shared mechanisms, a lot of overlap. Natural history sometimes lumped in with non-specific effects, but in my mind, it's something very different.
We've touched on it in prior episodes, but for people that maybe aren't familiar, can you briefly discuss what natural history actually is and means?
Yeah, it's going to be, first of all, it's going to be different depending on the disease that you're working with, right? The natural history of COPD, for example, is not very favorable, and the prognosis is not expected to be great. Same with multiple sclerosis, same with in many forms of cancer. What's different is in musculoskeletal problems, a lot of times the natural history, if we just leave it alone and let the body heal itself, is typically favorable. And with that being the case, then a lot of times that we're working with a patient in the clinic, we're seeing benefits from our specific effects. We're seeing benefits from our shared mechanisms or non-specific effects. And we're also seeing that time-oriented benefit of natural history. The person's healing on their own. So in many cases, letting time do its work is as powerful as doing the things with the patient.
And that's where it becomes hard to know what was the reason or main contributors to why someone experienced symptom relief or a positive outcome because of all of these moving pieces and variables that you discussed. Maybe one more definition that you just mentioned, regression to the mean. How does that play a role and what does that mean?
Yeah, so typically on those initial visits, the patient will actually score in the outlier category, either as a message to their provider that this is really severe or a lack of understanding of what they're dealing with. So the scores are essentially either this way or that way, to the left or right. Over time, people tend to regress to a common mean, and the results, even in interventions, you see results tend to regress to a central point where everything is very similar. To me, it's kind of a measurement phenomenon more than a natural history, which is something that occurs more physiologically or psychologically. But it is something that definitely happens when we evaluate our outcomes measures.
Going back to specific and shared mechanisms, why are they important to study? And what is the current landscape of research on this topic in musculoskeletal medicine?
So most of the work is done in the psychological literature. I think one of the biggest reasons it is beneficial is because we have a lot of different philosophies, a lot of different intervention choices, a lot of different people pushing different intervention forms, right? My way is the best way. You should do it this way. You should only do it this way. In reality, most of the research shows that has looked at this is that probably shared mechanisms are more responsible for the changes we see with our patients than the specific mechanisms of that particular intervention. And that said, it allows us to target some of those shared mechanisms and address those and help that patient, knowing that they work across all different intervention types. So if you're using exercise or if you're using cognitive behavioral therapy, if you're using manual therapy, you recognize there are shared components that you can also emphasize, such as therapeutic alliance or working on the patient's negative cognitions. And all of these things are going to lead to a more favorable outcome than if you don't address those. And the other thing is that we know that if we look at the comparative effectiveness of most of our interventions, they tend to be about the same, that there's not a lot of difference between exercise and manual therapy. cognitive behavioral therapy, and even some less conservative interventions. They all have similar outcomes. This helps explain that dilemma that we see, that mind bender of why do we see such, why do we always see these null findings when we compare these in good trials? It helps explain to clinicians why we see what we see. And to me, that's the biggest reason I explore it, is because I have always been fascinated by that. I noticed that there were very little differences between clinicians who had very different approaches to management, and everybody tended to get about the same outcomes. And there's a reason.
And would this also be included, the importance or the value, or maybe a large portion of the treatment effects from these shared mechanisms? Would that also be true for some conditions where there's a true or a significant deficit in physiological functioning from a postoperative standpoint in regards to postoperative ACL rehab or tendon repair or shoulder replacement, whatever it is, where maybe more of the specific mechanisms are more powerful or more warranted? Is that true, or does this fall still under a lot of the benefits in those contexts are still shared mechanisms?
Well, we don't know. It needs to be evaluated. I would argue that conditions in which involve an experience like pain, the pain experience, are probably going to be more susceptible to shared mechanisms than conditions that are where the disease mechanism is highly defined, or where the specific effects of the intervention is going to be very clear on how it addresses the problem. And I'd like to give you an example, if you don't mind. We recently completed something called the SHORT trial. And what we did is we compared about 200 individuals who received a reverse shoulder replacement. And they either received a home exercise program or they received physical therapy treatment. And the overall outcomes were actually the same between the two. And when we met as a group, and this included a lot of surgeons as primary investigators, when we met as a group and we talked about why we found what we did, it's fairly clear that probably the specific effect of the surgery itself and what is actually being done and how mechanical it is and how it's very much, if you think about it, it's like replacing the starter in your car or the alternator or something like that. It's very, very straightforward mechanical. That's probably why we saw very similar outcomes and not any variation with some of the things like we would typically see if we treated non-specific low back pain, which is very heterogeneous, or non-specific neck pain, or rotator cuff related disorders, or some of these very vague conditions, which can heavily be influenced theoretically by shared mechanisms.
And for these shared mechanisms, knowing that something like exercise or manual therapy or cognitive behavioral therapy, they share a lot of these mechanisms, and people can get benefit from a variety of these interventions for maybe similar reasons. What do you think is the explanation for maybe some individuals benefiting from certain therapies and them not benefiting from the others if the mechanisms are relatively similar?
Well, I think first of all, we do know that patients respond very differently to even efficacious interventions, which can be very frustrating in the clinic, right? And there's a wonderful paper by Edwards and colleagues, and the Impact Group from 2016, where they actually outline, I think there are 6 reasons why we typically see that. And what's really nice about it is they talk about, again, it's efficacious interventions, even pharmacological agents. People respond very differently to those. So in my mind, what is happening is the specific effects influence people differently. So it's not that the intervention is different and its specific effects. It's the way the patient actually takes those as a therapeutic action within their body. So since people respond differently to different treatments, it's up to us to really fine tune it and find the intervention that fits for that particular patient. And it is going to be different. And we've all been there where maybe one patient, we start to do some cognitive behavioral work with them, motivational interviewing, and they give us one of these, time out, and they basically say that, that stuff doesn't really work with me. We don't need to do any of that. And I've had patients say that to me. Or I consider use of manual therapy. I talk to the patient and they say, I don't really believe in that. I'd prefer not to have that. Or a person who says, I'll do the exercises when I'm here in the clinic, but I'm not going to do them at home, and I'm not going to carry forward into them either. So there are going to be variations, and it's about finding the right fit for the patient. And that's both, I think, physiologically and psychologically.
And I guess that's really helpful and relieving to know as a provider, because there's a lot of options and it can be very personalized, and that a patient can be aware of that they don't have to feel in this rut that if this specific treatment or intervention isn't helping, that they're doomed because that was the one special only option.
Completely agree. And I know that, and you've had some really great researchers on your podcast, and I'm not sure everyone would agree with that. I know that some researchers are very wedded to a particular intervention type, or they're very anti one particular intervention type. But if we look at the evidence and we look at an RCT and we actually look at the people that benefit, who benefits and who doesn't, there's a mean, an average treatment effect, and then there are people who don't benefit, maybe even worsen, and there are people who are exceptional responders. All interventions demonstrate that in trials. And the key is understanding who they are and figuring out someday, because we haven't figured it out yet, ahead of time, who is likely going to be one of those individuals who are going to benefit from that intervention. But that's what the evidence supports. That's one of the reasons we see these null trials in well-done comparative effectiveness studies. And it's also one of the reasons I'm so fascinated with studying mechanisms, because if we get to the point where we can explain this in a way that's meaningful to clinicians, I think there's going to be a lot of relief. And it's going to take away a lot of the, I know as a clinician, I felt very guilty if a patient didn't improve under my watch. It may help explain why we're seeing what we see in the clinic.
The process of studying this currently and moving forward, it's quite a task, but you touched on or wanted to dive into the process of studying this and what you all are currently doing with certain trials. And you mentioned the idea of discussing first, second, and third order questions. Can we dive into that? What are those and why is that helpful or necessary?
So first, second, and third order questions are essentially, if you go to the research literature, it's talked about, and it's not common vernacular in physical therapy. We wrote a paper about it a while back. The lead author was Amy McDevitt out of University of Colorado, and Amy is a collaborator of mine on the SS Mech trial. But a first order question basically asks the question, does this intervention have efficacy or effectiveness? So it's essentially, a first order question would be, you would answer it with an RCT and you would look at a comparative effectiveness study. And it just basically tells you, are we dealing with snake oil or not? Are we dealing with something that has an effect, a clinical effect? A second order question is why? Why do we see the clinical effect that we do? In other words, what are the mechanisms behind that clinical intervention? Is it specific? Is it shared? What are the reasons why we're actually seeing? What are the treatment mechanisms affiliated with that? And that involves a completely different study design than a randomized controlled trial. That's often what we see in animal studies or preclinical work. You can actually do human studies too. It's just your outcomes are completely different. You're doing blood draws, you're doing imaging, you're doing saliva swabs, you're doing, mechanistic capture with that. A third order question is, who does this treatment benefit? And instead of the spaghetti on the wall approach, which we've consistently used for years, a third order question requires a moderator analysis and the ability to go in and actually say, okay, they have these characteristics at baseline. That suggests they're going to benefit from exercise, or that suggests they're going to benefit from some form of psychologically informed care process. The challenge is we haven't been good at that yet. Those studies are exceptionally difficult to do, as are a lot of the mediation designs necessary for a second order question, which is the mechanistic questions. Those tend to be very expensive. A moderator design also requires an RCT, but you have to have a very large study, 350 to 400 subjects, to be able to have the power to run a moderator analysis. So in many cases, we don't have the answer to second order questions. We don't have the answer to third order questions, but we're really good with first order questions. We know which interventions are snake oil and which aren't.
And that trial you briefly touched on, the SS Mech trial, is that currently an example of trying to dive into those second and third order questions?
Indeed, it is. And so the trial's been going on for a year and 1 month. The collaborators is Amy McDevitt, as I mentioned before, but also Brian O'Halloran from MUSC, and then Frank Keeve, who is an icon in psychology, is also involved in this. We were funded by the PT Foundation, and we are now at 120 subjects. We are going to go to about 130. It is an RCT where we're comparing an all manual therapy approach versus an all exercise-based approach for patients with chronic neck pain. And what we've done is embedded a number of mechanisms captures within the trial itself. So we'll be able to see the relationship with the mediation analysis of those mechanisms to the clinical outcomes at the end. Our goal is to see if the same mechanisms, shared mechanisms, are the reasons why we see the clinical outcomes we do with manual therapy versus exercise, or whether it's the specific mechanisms affiliated with manual therapy or exercise that are the reason we see the changes that we do in those interventions. There aren't many like this. There's a couple in psychology. There's a few studies in other professions. But with respect to MSK, I know of ours, and there might be one I know there's one out of Australia that's ongoing, but it's a pretty rare design.
And how do you sift through those shared and specific mechanisms in that analysis?
So you use something called a mediation analysis, which is fairly complex. But basically, you're looking for how that particular mechanism mediates the relationship between maybe a baseline characteristic of pain and a discharge characteristic of disability. So you're looking at whether it drives, if you see a positive relationship with that, or you see no relationship, or maybe there's a negative relationship with that. I think the key is identifying ahead of time which mechanisms you want to capture in that intermediate phase, with the assumption that those mechanisms are really the ones that are leading to the changes in our patient. So we've captured a variety. We're capturing what we call indirect mechanisms because we're not doing blood draws, we're not doing swabs. We're basically doing clinical measures such as range of motion. We're capturing endurance. We're capturing pain pressure threshold with an assumption that pain modulation may be one of the mediators. And then we capture a number of psychological variables such as psychological stress. We capture a measure of therapeutic alliance, and then we do capture a measure of fear as well.
And do you at this point have an idea, or are you able to discuss what some of the findings are?
Well, we haven't broken the code for the mediation analysis yet because that's going to take the full numbers. But we are required for our IRB to have interim analysis at different cycles. So a halfway point, at the 3/4 point. So I do have, at 104 patients in, I do have the comparative outcomes. So pain interference, pain intensity, and the PROMIS function score. And what's interesting, at 4 weeks after 5 visits, there's absolutely no difference in pain interference and pain intensity between exercise and manual therapy. No difference. There is a statistical difference in the PROMIS function score. But between you and me, it's probably not clinically significant because it's essentially less than a point. So if I had to look at the data and interpret it, if we were stopping tomorrow and only using 104 subjects, and again, we're capturing 6 months out too, so we're going to end up having a full 6 months of data. If it was just 4-week data in a comparative analysis, I'd say there's no difference in outcomes between the two groups, between the two interventions. The reason why, we hope to figure it out pretty soon.
Can you elaborate on that all manual therapy group and the all exercise, what those two separate treatments look like?
Yeah. First of all, one of the things that we've wanted to do is make sure, because there's a lot of weak fidelity, the interventions are kind of poor in a lot of RCTs. So we really wanted to make sure that we're given good care in these arms. So the exercise arm, there's a lot of endurance-based exercises. We target both global and local muscles. We also target the upper quadrant, and there's a home program that is reflective of that as well. The patients will often exercise anywhere from 30 to 35 minutes in the clinical environment, and the home program is a pretty robust home program. So a lot of anterior neck flexor strengthening, posterior neck strengthening. We have a lateral strengthening exercise, and then all kinds of scapulothoracic work, anything related to strength and proprioception, kinesthetic awareness. So there's a lot of isolation-based exercises at particular joints. If you've ever taken a Con Ed course with Gwendolyn Joel, it's going to have her fingerprints all over it, the way that she actually addressed a lot of the care processes out of Australia. I think it's a really good program. And we're seeing pretty notable changes in the PROMIS scores from baseline to 4 weeks on these patients with chronic neck pain. The manual therapy approach, the only thing that we don't incorporate is manipulation, and that's primarily to meet the safety requirements at our IRBs. So we use a lot of mobilization, a lot of soft tissue stretching. There's some soft tissue mobilization with it as well. And it's all going to be reflective of what we feel the patient's needs are. So there may be certain areas that we'll work on more upper cervical or lower cervical, wherever the patient will often complain most of their symptoms. We also work the thoracic region, do some just general stretching throughout the upper quarter. And then the whole program is a self-driven stretching program that the patient does. And there's no crossover, right? The manual therapy folks don't do any endurance or strengthening, and the endurance and strengthening folks don't do any mobility-based exercises. We try to keep it very separate.
And with either group, the provider during those in-person sessions, are they told to explain specific rationale as to why the exercise group is doing this and the manual therapy group? What are they allowed to say or not say?
Yeah, so first of all, the patients know what the group allocation, so they're not blinded to that, because there's no way in the world you'll be able to explain to them that manual therapy is exercise. So that's a piece of it. We knew we could blind that. But part of the study is enhancing the therapeutic alliance aspect of this. So in both groups, we spend a great deal of time trying to build that relationship with the patient, explaining to them what we're doing, explaining how they can carry this forward on their own, and how this is something that they can self-manage with. So we really are looking to see if we can make a difference in the alliance assessment over time, so that that patient feels like they've really bonded with their clinician. So that's a big part of our intervention. We've seen some studies where you don't communicate with the patient, you don't tell them the rationale behind anything, you're not motivational, you're not a good clinician. We're the opposite. We almost overdo it in this thing, because we do want to measure how much therapeutic alliance actually influences the overall outcomes.
And the manual therapy only group, are they told not to perform any general activity or exercise on their own if they were already?
We allow individuals, since they're randomized, to continue to do their own exercise program or continue to take the medication that they have taken from the beginning. We don't control for that at all.
Okay, got it. Okay, so that trial is underway. Time will tell. What else do you want to dive into with the specifics of the current research landscape with these specific and shared mechanisms? Or do you want to go into more of these kind of clinical implications for the day-to-day clinician and how we should use this information to help us at this current state?
Well, I want to mention that we are submitting a grant in which Amy McDevitt is actually the principal investigator. And in the study, it's a 3-arm trial. And our goal is to identify the proportion of specific, non-specific, and natural history. So this particular study will have a specific effect component where they'll get a very robust manual therapy program. The comparison group will be a sham group that will get all of the setup of the normal manual therapy, but no thrust, no mob. And then the third group will actually be a no care group that'll purely be a wait and see, let's see what happens. We'll be able to look then by using the formula that we have to evaluate what proportion of the overall change in the health related outcome is attributable to specific, non-specific, or natural history. There's a lot of debate on that. I mean, some of the literature suggests that non-specific or shared effects could be anywhere from 10 to 85% of the overall outcome, which I think is probably 85% is way too high. I think most likely it's going to be, other literature says it's more in the 15 to 30% range. And our hopes are to evaluate that in manual therapy, because there's a lot of concern about manual therapy being more non-specific, more related to therapeutic alliance, the relationship with the patients, that sort of thing. We'll see. But if we get that grant, then we'll have something interesting to talk about in the future.
What should the day-to-day clinician consider or think about with all of these research heavy topics, but you distilling it down as a researcher? What are kind of these big takeaways or things to consider as a clinician?
So everybody has experienced and what my friend Stephen George calls opening the magic effect box, right? Where the patients had chronic problems, chronic back pain. They go see a PT, and within that single visit, they'll say, "I'm 50% better. I don't know what you did." And the PT says, "I don't know what I did either." So that part of it, that huge change that actually occurs, we're trying to quantify that. With the recognition that it isn't always going to be the specific effects or the things that we were trained to do when we went to PT school, or the things that we were told what was going on. It's going to be other things that we don't always measure, or other things that we don't even know what to measure yet, that it could be happening that we don't even know what it means. I want the clinician to know that there's a lot of stuff that goes on in the mind of the patient that can be therapeutic. And often the little things that you tell them or what you explain to them or what you have them go through. And I know you had Peter O'Sullivan on, and he does a really wonderful job with this, of just talking people through their current condition and kind of relearning for the patient of what they can and can't do. So the things that you tell them to reframe their condition, that would be the takeaway from that. That's a non-specific effect. That's a shared effect among a number of treatments. And those can be very, very powerful and can be very, very much a bonus component of the treatments that we do.
Do you think that communication, the reassurance, the guidance through navigating an understanding of what someone's dealing with and managing is the biggest priority or thing to focus on with any of these interventions? It's the surrounding narrative and alliance and discussion around these topics?
I think right now, Chris, it probably is, because you'll make immediate gains from it. And it is something that can be learned. I'm not naive enough to think that a clinician can go to a weekend con ed course and go back and all of a sudden they're this silver-tongued motivational clinician that has figured out how to change the landscape for their musculoskeletal patients. I think it takes a lot of effort. I think it takes trial and error. I think it takes a person consistently reflecting on what they're doing so that they're not drifting back to the habits they've had before or the way that they've always done it. But I do think there's immediate gain with that. I don't think it's the biggest thing on the horizon, though. I don't think that's, as research moves forward on improving how we can manage patients with musculoskeletal disorders, I actually think there are some better things that we can do than just nudging that patient with shared or non-specific effects.
What do you think those things are?
Well, I think the third order questions are really going to be the ones that make the greatest difference in how we manage our musculoskeletal patients. But one of the challenges to that, of course, is that we're going to have to understand the disease mechanisms of our musculoskeletal problems a little bit better. And I would argue we don't understand it that well. Rotator cuff related disorders, is it a tendinopathy? What exactly are we do? Is it fatty content within the tissue? What is it? Is it a loss of strength? Probably not. Non-specific low back pain. What isn't it? I mean, it's like everything, right? So until we understand those a little bit better, I think matching the patient to the type of intervention is going to be a little bit of a challenge because of the heterogeneity in what we're dealing with. But a third order question, when done right, can very much drive you into a certain direction for treatment. And can I give you an example from our short trial of what? So we actually ran moderator analyses in the short trial of trying to identify, are there selected characteristics in which if the patient had these characteristics, they actually did better in the PT arm of that shoulder replacement, or they did better in the home exercise arm of the shoulder replacement. And we only found one. And the key moderator was a person that was motivated to improve their health. So we used a scale, essentially motivation for improved health. And those individuals who had high motivation for better health did much better when they were placed in the PT arm than when they were placed into the home exercise program arm. So because of the mechanical nature of the intervention, everybody got better. But those folks that were really motivated about their health and they wanted to do more and they wanted to get back to doing things, they actually did better in the PT arm. That's a moderator design.
They did. So the people that were more motivated did better in the PT versus them doing it themselves in the home exercise or home rehab.
Versus their counterfactuals in the home exercise program. Yes.
Why do you think that is?
I'm not sure, other than the fact that they're getting a directed form of recovery. They have a kind of a personal health coach in the PT that kind of drives them forward, that provides goals for them, gives them a vision of what recovery might look like. What are the ceilings on that recovery? What are the do's and don'ts? I just think it creates an understanding of where they can go with their condition that fits within their goal of better health.
So just so I'm understanding, the people that were scoring high as motivated, but they were in the other treatment arm, they did not receive as good of outcomes?
Correct.
Got it. So yeah, I would have thought it would have been either similar or the opposite, knowing that if they're as motivated that they can kind of do this plan independently and have the resources in preparedness to do it. But that doesn't sound like it's the case.
Yeah, it was completely flatlined. If you look at the motivation levels, on the y-axis, and then compare the x-axis, and then you compare the actual outcomes on the y-axis, it was completely flat for the HEP group, where it was completely spiked high on the PT intervention group, showing that the more motivated you were, the better you did with PT. And in the other hand, the more motivated you were, it didn't matter with the HEP.
What else do you want to touch on, Chad, before we start to kind of close things out or provide some summary?
I guess one thing, and it's not meant to be contentious, it's just meant to be, I think, explanatory, is that there's a lot of, historically, I think, especially on social media, there's a lot of this intervention is better than that intervention, and you should never do this intervention, and almost like an intervention war, right? In many cases, people are making profound statements with really very limited ammo to talk about. And sometimes they make these statements based on, everybody should get, this type of exercise because in this particular comparative effectiveness trial, this intervention did 2 points better than in this intervention. Well, RCTs are not designed to tell you who should receive an intervention or not. They only tell you if you're dealing with snake oil or not. They never tell you who is likely to benefit from an intervention. That's a third order question. and they never tell you why. That's a second order question. And that's a big mistake that people make. So in that individual patient in front of you, they may or may not benefit from that intervention, regardless if it did well in an RCT, because every RCT is built on average treatment effects. The average treatment effects will be a mean compared to the other mean. And then there's the tails between that some people did worse, some people did better. So those individuals who were in the RCT, who were in the group that did better, but were in the tail that where they actually did worse, I would argue that that's not the right intervention for them. They should probably need a different intervention. Maybe it's one we don't know about. So average treatment effects only tell you if one intervention on average is better than the other. They don't tell you who's going to benefit from it. That is such a huge misconception, even by researchers, which is somewhat stunning to me, which is also why you can never, which is why clinicians who work with individual patients need to make individual decisions about those patients. They don't need to make average treatment effects decisions.
You said kind of snake oil a few times. Can you, if you feel comfortable, talking about what are some of the snake oil things in musculoskeletal medicine that probably should not be performed?
Yeah, things that have no effect outside a placebo effect, so no therapeutic effect whatsoever. I would argue that a lot of the taping, therapeutic taping, probably fits into that category. I think there are certain types of really complementary and integrative approaches will have no actual therapeutic effect. It's probably all just placebo effect. Exercise has an effect. We know that it has a specific effect. We know that manual therapy has a specific effect. So does cognitive behavioral therapy. Most of their effects are similar. A lot of our modalities, some of our modalities actually have an effect. They're not real strong. Ultrasound probably has a very marginal or trivial therapeutic effect. What we see typically in the clinic, if indeed a person has a bump up from that, it's probably either natural history or some sort of non-specific effect like a placebo.
The options that a patient can and should maybe have outlined to them, as these are a variety of strategies that we could go about experimenting with to see if this is going to move the needle forward or help in your care. Like you said, there's so many: manual therapy, exercise, cognitive behavioral therapy. Do you think that a practicing clinician should be extremely well versed in all of these and be as equally open to providing all of the potential options? Or what are your thoughts on a clinician that's more oriented towards the MI and CBT and kind of talk-based conversations or therapies, or you know, that area versus a manual therapy versus an exercise biased, the individual clinician having their own preference? And if there's an understanding that this is where I feel comfortable or I'm the most confident providing care, and if this is not, we feel that this is not the right fit for your care, then I'm going to refer you to this provider that really values and performs those other therapies really well. Do you, I guess, think that everyone should be equally well-rounded, or there can be these kind of biases, but acknowledging that if this isn't the right match, we go to these subsequent other professionals?
Yeah, it's a great question. And there's a lot to unpack there, and I'm going to try to give it a go. I'll start with the easiest and laziest answer. And that's, there's probably not going to be a huge difference between people who have dedicated biases and their interventions. Just like in our approach, where we're comparing exercise, a good exercise program to a good manual therapy program, there's no difference. And it's probably because there is no difference. And it's the same thing if we had a good cognitive behavioral therapy approach versus a good exercise-based, there'd probably be no difference. So that part of it is, you know, the laziest. With respect to a clinician's biases, we've actually measured that in 2012. It was part of our RCT where we compared manipulation versus mobilization, and we wanted to see if a person's personal equipoise, if they had a bias toward one intervention versus another, could it potentially influence the overall health-related outcome. And it did. There was an interaction curve, and it actually was significant, meaning that the person's preferences are going to definitely overlay on that patient. So if you have someone who is, historically born and bred to hate manual therapy, and you're not going to indoctrinate that person into using manual therapy consistently in a way that's probably going to be meaningful for a patient, because their beliefs, again, very much transfer to the patients. And we've seen that. Mark Bishop's group out of the University of Florida has shown that too. I think the best method then would be a clinician understanding that most interventions are quite similar in their overall outcomes, but because of patient preferences, because of what you're dealing with, whether it's a time crunch or the individual unique situation of the patient, their fragility, their whatever, there is going to be a better selection for that patient. And the ability to walk that through, have a conversation with the patient, and where you jointly make that decision together, that's going to be the most important thing. There is literature that if we pitch our interventions as if they're a smorgasbord at Golden Corral, that basically they're all good, pick any one you want, we actually see negative outcomes with that. So you definitely don't want to do that either. It's very much and I'll ask the patient, what in your mind, or from what you've Googled or whatever, what comes to mind is what you think you might need, and then have them talk a little bit about it. And then I'll talk about, well, we have an intervention similar to that. Here's what we do. Does that sound similar to what you had in your mind? Because I believe it might be beneficial for you too. And then you've got two minds coming together, working as a unit and adopting a particular intervention. That's, I think, probably from what we have right now, with the science that we have right now, is probably the best.
Yeah, I find myself struggling trying to outline options depending on their interests, their resources, my preferences, their preferences, etc., while discussing some of the potential benefits without being too broad and it feeling paralyzing for them, because now they have too many options. But me realizing that a lot of these things are probably going to be similar in their outcomes, or if someone wants a hyper specific approach and I'm not giving it to them, it's kind of that fine line of knowing, okay, this is what they're valuing and this is what they want. I don't think it needs to be this hyper specific, and I maybe touch on that, but I still create it because that's their preference. But It is hard to navigate some of that, discussing some of the uncertainty of still why some of these things work, even though we have a variety of options and we know that some things do work, without it feeling like it's just too vague or too general.
And you're right on. And it is very difficult, I think, if we look at the literature. Most of the way that we explain how things work is going to be based on averages and not on things that are specific to individuals like them. So that part of it is a hard sell for a patient. I do have one thing to add, if you don't mind. Again, and this may be something that your listeners may not want to hear, but indeed, most outcomes are similar across the different interventions. There's a really fine paper from Adam Lutz and his group out of the United States. And Adam is a data analysis guy. He's a PT by training, PT PhD, but he gets these mega data sets and he looks for treatment signatures, and he categorizes exceptional outcomes, exceptionally poor outcomes, and then kind of the group, the similarities right in the middle. Well, the majority of people have about the same outcomes. About 80% of PTs will have the exact same outcomes. And they use a variety, a cornucopia of different interventions, right? It's a bunch of different things kind of all thrown together. But there are treatment signatures related to exceptional outcomes and exceptionally poor outcomes. And I'll talk about the exceptionally poor outcomes first. The individuals who had the worst outcomes in the sample of 150,000 patients who received physical therapy was all exercise based, and it was not adaptive to the changes in the patient's condition. So basically, they got an exercise program. That exercise program never changed. And it was just where they plowed through no matter if that patient came in feeling better or feeling worse. There was no adaptability whatsoever. In the exceptionally good outcome, which ended up being about 10% of the clinicians, these clinicians were very adaptable to the patient's day-to-day condition. So the approach changed markedly depending on how that patient was for that day. The clinicians were more likely to use manual therapy in addition to exercise, whereas in the exceptionally poor group, there was no manual therapy used. So in my mind, what that tells me is that the exceptional clinicians are the ones that are adaptive. They respond differently to the patient. They meet the needs of the patient at the day that they see the patient without the failure of losing track of the direction you need to go with that patient. So I thought that work was phenomenal. That's what we've seen in the clinic. And, somebody actually had the audacity to say, well, you need a bigger sample to really able to tease that out. I think 150,000 is a pretty good sample. But great researcher, great work. I really like what they're doing, looking at treatment signatures.
Yeah, that parallels to some of the common experiences that I've heard from patients where I've asked if they've had prior bouts of physical therapy or what their experience has been. And if it's that path of or experience of disappointment or frustration, a lot of the similar explanations was, I was thrown to do these exercises in the corner, or I had no one checking in on me, or I did the same thing for 12 weeks. And it was this sensation or perception of being dismissed or not being, guided appropriately, not having someone present with you. And I think that's a lot of what you're kind of describing.
It is. And I'm a big data researcher too. I've had data sets of 50, 100,000 physical therapists seeing patients. So that'd be 50 to 100,000 patients. And when we run any of the analyses, any of the cluster analyses or latent class analyses, and we look at treatment type as a predictive variable for outcome, it's never significant. It's always something different. It's more patient level factors. It's more experience-based factors. It's other things that you wouldn't normally think. And so those things to me should help modify how we should function as clinicians. If you're that PT that makes the patient feel like they're the only person in the world when you're with them, and you're doing, you're responding to what that patient is telling you, then I think that's 90% of the battle right there on being a good clinician. And it seems to be that the data are supporting that too.
And it is tough in a lot of these clinics where it's just so high volume and it's hard to have that, strong therapeutic alliance and presence, or if the patient's being thrown between 5 different providers or 2 primary PTs and then 3 PTAs and techs. It's an uphill battle. I had a eval earlier this week where a patient was in a setting that was a higher volume clinic. She had seen multiple providers. She had seen a lot of PT assistants and techs. And I'm fortunately in a facility where I have 45 minutes one-on-one, and I know that can be really rare now. But I said, fortunately, you're going to be with me this whole time during your whole plan of care. We're going to have this one-on-one interaction. And she, I think, verbalized like that alone just makes me feel a lot better. And It is just that ability. But I'm aware that that's a lot of times really hard nowadays in outpatient orthopedic PT, where a lot of providers just don't have that time and availability, and they're seeing 2 or 3 patients at a time. So it's a tough position to be in, both as a patient and as a clinician.
So I'll just say this: good on you for being in that environment. I don't know if you own the environment or your owners. Good on them for putting that together. I agree that is meaningful. We have all dealt with medical providers the same way, right? If we've ever had conditions, if you've got that medical provider that is with you, that communicates with you in the electronic chart, that makes you feel like they're on top of it, they and you, it makes a huge difference. And just went through something in the fall like that. And it was a brand new primary care physician. This guy was amazing. And I told him, I said, I've never experienced this before. It's always been in and out. And that makes a big difference, I think, especially to patients who are in a vulnerable situation.
Chad, I think this was an amazing conversation. Is there anything else you want to summarize or touch on before we fully close it out?
No, again, I want to say, keep doing what you're doing. You're reaching a large audience. You're bringing a lot of really varied discussion points to your podcast. I think that's super interesting. One of the things I love to do, and a lot of the research ideas I've gotten, is by going somewhere else and listening to different people. And I really commend you for doing that. And bring people on with very different viewpoints. I think it's a great approach, and I wish you best of luck moving forward.
Thank you so much, Chad. We'll call it there. We'll link some of the papers that we've touched on and highlighted here in the show notes. And we appreciate all the work you're doing and will continue to do in the future.
Thank you.